The other thing that we're looking to tease out in this new era is not only efficacy, but also safety, right? I mean, can you comment from your study the adverse event profile in lenvatinib in this second line plus population? Did it differ from what we would expect from a frontline population?
Yeah, so for, again, looking at the retrospective review, our adverse events profile looked somewhat similar to what was in REFLECT trial. We had about 83% of the patient had any grade 1 or 2 AEs with lenvatinib, with most common with fatigue, some increase in LFTs, and there were some symptoms like abdominal pain, diarrhea, anorexia, and so on. But the grade 3 or 4 toxicity, which was seen in about 39% of the patients, with most common being hypertension, which, as we know, is counted as a grade 3 at pretty high rate, even with a slight increase. And then the rest followed by very rare side effects like fatigue, AST elevation, anorexia. So those were all pretty rare, but the most common was hypertension. And I think this is very, very consistent with what was in REFLECT trial. So at least from the adverse event profile, we did not see anything new signal that we would be worried about. Secondly, I think partly based on our reviewer comments, we actually also looked at patients who had grade 3-4 AE and clinical outcomes, which is more commonly again done in immunotherapy era. And we did find there was a slightly increase in the PFS and overall survival on the patients who had higher grade 3-4 AEs. So patients with median PFS was 8.1 months versus 3.4 months. And similarly, survival was about 19.5 months versus 11.1 months. Again, I'm not saying that patients who have grade 3-4 AE definitely have better survival. I mean, I think we have to be very, very cautious about that conclusion. But at least in the trial, it was suggestive of a little bit higher clinical outcomes and might be related. Maybe that hypertension is a biomarker of response or biomarker of effect of the drug, at least.
Yeah, that's been looked at in the clinical studies, right? Correlating proteinuria, hypertension. In the case of sorafenib, hand-foot skin reaction, that patients who have these toxicities may do better as far as disease control, and that was an interesting thing to look at. I mean, you did an interesting analysis looking at perhaps some patient characteristics that might be associated with better outcome with len in this population, and this is an important idea because there's been this idea that perhaps fatty liver or NASH, and now they've changed the name again, but essentially non-alcoholic steatohepatitis related liver cancer might have a different natural history. Could you just give us an insight into what you learned from your univariate and multivariate analyses in your population?
Sure. So we looked at very different factors, including age, demographics, typically age, gender, race, Child-Pugh status, the liver function, and as well as you said, the etiology, whether it's hepatic viral etiology versus MASH. And as you mentioned clearly, right, it's very different with the TKI response or even with immunotherapy response between hepatitis B, C versus MASH, although some of the reports are contradictory. At least, again, in the small study of 53 patients, we did not find any relation to the etiology of the liver disease in terms of the outcomes, especially if you're looking at overall survival. We did find that patients who are female, white, and better Child-Pugh status did have more prolonged survival compared to patients who were males or other races, and obviously poorer liver function. In terms of the PFS, we found that BMI and the presence of metastases were the risk factors which would determine PFS. But for the survival, again, it was mainly female, gender, white patients, and better liver function who did better.
Interesting. I mean, the liver function, I think we can explain, biologically, that's an important prognostic factor we know about. Women, it might have just been a smaller subgroup or something, because I don't know how much that has been teased out, in other phase 3 studies. But one idea, and I don't know if this stood out, is length of time on prior immunotherapy, right? Because this is something clinically I wrestle with. We know that patients who progress very quickly on frontline IO, meaning their best response is progressive disease, have a very poor prognosis. and sometimes I wrestle, do I try a different IO regimen in those patients? CTLA-4 and PD-1 if they progressed on PD-L1 and Bev type of approach, or do I go to a TKI, right? And were you able to tease anything out, like prior response or anything, and how they did with Len?
Yeah, so that's a great point. Again, I think as I mentioned, this was a little bit study when we had a little bit of a hodgepodge of treatment options, right? So we are actually doing a follow-up study with very pure, where we are just using atezo-bev as a first-line option and looking at that in terms of, as you were mentioning, length of time response or the best response on immunotherapy and how that predict treatment outcomes for patients who receive TKI following that. In this study, we were not able to tease out just because of the different regimens. It just becomes, again, with those much smaller numbers. But you're clearly correct. I mean, general patients who progress, right, primarily on the first treatment usually don't do that well on the second line or third line options. But hopefully in the future, we will have those results.
Yeah, well, that's an important data set you're working on. And this is congratulations on a nice study. It's adding to other data sets of real world evidence in the new landscape of liver cancer, and our patients are continuing to do better. I think it's very gratifying for all of us to see. And until we have prospective data of how to manage these patients, real world evidence will be important for us. And in closing, personally, how do you manage your patients who are progressing on frontline IO? I mean, what is your sequence, so to speak?
Yeah, it's very difficult to say what should be but at least from my practice, first line is typically atezo-bev, unless there is some contraindication for bevacizumab, whether relative or absolute, then we use durvalumab. And then second line options, typically we use tyrosine kinase inhibitor, which includes either lenvatinib, rarely sorafenib, but cabozantinib is another option as well. And now I think with durvalumab get approved, there's some at least consensus that maybe we could try immunotherapy again, maybe in the second or third line. I probably consider for third line, especially for someone who had prolonged disease control on atezo-bev. But again, with limited experience, I think, using the PD-L1 plus CTLA-4 after progressing on some sort of IO, I think the outcomes are obviously not as good, but we'll continue to monitor. But hopefully if we select the right patient population, those are patients who could be long-term survivors. But as you mentioned, the biggest thing is I think we didn't have these options and we didn't have long-term survivors in HCC for majority of patients. And I think we really have changed the landscape where patients are living longer and longer, and we're talking about different treatment options.